Hi guys, today we'll be talking about deep vein thrombosis, its relation to orthopedics, its diagnosis, and the thromboprophylaxis we usually use in orthopedic surgery. So, coming to it. So, let's just start off with something called virtuous triad. So, what is virtuous triad of thrombosis? Any of these three factors, when affected or disrupted from its normal physiological parameters, can lead to thrombosis, especially if all three are disrupted. Anything that increases the density or the thickness of blood or the hypercoagulability of blood. So when a person has cancer, when they have a protein CNS deficiency, anything that causes endothelial vessel damage, anything that damages the endothelial lining of the vessel, whether doesn't matter what it is, can lead to thrombosis. And thirdly, stasis. In orthopedics, we are known to immobilize patients in casts and slabs. And also, after imagine there's a paraplegic patient after spinal cord injury, there will be stasis of blood and they are predisposed to thrombosis. Okay, this is the virtuous triad of thrombosis. So, combination of all three or one can increase an individual's risk for thrombosis. So, what is deep vein thrombosis? It is a thrombosis that occurs in the deeper veins in the leg. The saphenous nerve, the saphenous vein that great saphenous vein, that is part of the superficial system of nerves which are connected to the deep system through a series of perforators. So, the deep system of veins consists primarily of the femoral vein, the popliteal vein, anteritibial, posterior and the peroneal veins. And of course, the femoral vein connects to the common femoral vein up and the external iliac, common iliac, and the internal iliac. All this can be affected in deep vein thrombosis of the lower limb. So, coming to the coagulation pathway in a very brief manner, just because I want to explain the mechanism of action of heparins, vitamin K antagonists, which are warfarin, direct thrombin inhibitors, which is an example of which would be dabigatran, and factor 10A inhibitors, and examples of which would be rivaroxaban and apixaban. So you can see vitamin K antagonists mainly act on factors 2, 7, 9, and 10. 2, 7, 9, and 10. What is the mechanism of action of heparin? So, in a normal state, there's something called antithrombin 3 floating around in the blood in inactive form. So, what heparin does is it goes and activates antithrombin 3, and antithrombin 3 in its active form acts on factor 10A and inhibits it and prevents the conversion of 2 to 2A, which is the conversion of prothrombin to thrombin. So that is the mechanism of action of heparin. As direct thrombin inhibitors, as the name says, prevents the action of activated thrombin from converting fibrinogen to fibrin. And since fibrinogen cannot be converted to fibrin, there's inability to form the fibrin clot, and hence disrupts the clotting system or the coagulation system. Sorry. And what is the mechanism of action of factor 10A inhibitors? Like the name says, they inhibit factor 10A, and when factor 10A is inhibited, prothrombin is not converted to thrombin, and hence they cause disruption of the coagulation cascade. Okay, coming to the next. So now coming to something called the two-level DVT Wells score. So what this score does is it should be done in all, ideally should be done in all pre-op cases of plasties like knee replacement and hip replacement. And what this gives us is an idea about an individual's susceptibility to formation of deep vein thrombosis. Okay, so it has a table here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 parameters, and each of these first 9 parameters carries 1 point plus, and the 10th parameter carries 2 points minus. So anyone with active cancer on treated in the last 6 months adds 1 point. Paralysis, or plaster mobilization of the lower limb leads to 1 plus 1 point. So you go through the entire thing and you add the points. And now if you end up with 2 points or more, the chances of DVT is likely, and the presence of DVT is also likely. And if there's 1 point or less, the chances of the presence of DVT is unlikely. So how do we apply this score? Coming to the next slide. So after assessing the well score, we come to this flowchart. So DVT unlikely, with if there's a score less than equal to 1, we send something called a D dimer. If the D dimer has a positive predictive range above the value given in the lab reference range, we do an ultrasound. And in the ultrasound, if there's a presence of DVT, we do a duplex ultrasound of the lower limb. Duplex ultrasound consists of to check whether the vein is compressible or not. Number one, if it's not compressible, it indicates the presence of DVT, and also it assesses the flow and velocity of flow through a point in the vessel. So it has two parameters. So if that is present, we treat with anticoagulation therapy, and if a D dimer is negative, then there's no DVT. We can rule it out because the well score is also less than equal to 1, and a D dimer is also negative. However, if the ultrasound is negative also, we can 100% rule out DVT even if D dimer is positive. Then, if the well score is greater than 1, D dimer is positive, we do an ultrasound. If the ultrasound is negative, we repeat the ultrasound after 1 week. And if it's negative again, then only we rule out DVT. If at any point the ultrasound is positive, we treat with anticoagulation therapy. If the D dimer is negative, here, unlike if the DVT score is less than equal to 1, we still have to do an ultrasound. And if it's positive, we treat with anticoagulation therapy. And if it's negative, we rule out DVT. Okay. So, coming to the management of DVT, please excuse the handwriting here. So, DVT is diagnosed, and in case of an individual where there's a high risk of bleeding, if we give anticoagulants, like they have a GI gastrointestinal bleed, they have an ulcer and it's continuously bleeding, if we give anticoagulants, then they'll probably bleed out through the ulcer. In such situations where anticoagulation is contraindicated, we can advise the placement of an IVC filter. So even if the deep vein thrombosis tends to migrate proximally, it will get blocked at the level of the IVC and prevents from going further. So this is what it looks like. It's like a basket, and it prevents the blood clot from traveling from distal lower limb proximally to the heart and causing heart and lungs and causing a pulmonary embolism. So if there's a distal calf vein, by calf vein I mean like the anterior tibial, posterior tibial, or the peroneal veins, it rarely propagates proximally and causes pulmonary embolism. And it's controversial whether or not anticoagulation is required for this, but in our institution we give anticoagulants anyways for a period of 3 months, even for a distal calf vein thrombosis, because patients do not follow up properly, and so we like to be on the safer side. If they have a distal calf vein thrombosis, they need to follow up every month or so and do a repeat ultrasound to keep checking for propagation. And our institution, that usually doesn't happen, so we tend to be on the safer side and give them anticoagulants. This is a popliteal or a femoral vein thrombosis. Anticoagulation alone is a must, and it's satisfactory enough in most cases, and only in selected cases with even higher risk of thrombosis, like a very high well score, then maybe we'll consider thrombolysis, which is the administration of ateleptase, urokinase, streptokinase, and all these other agents. If there's a thrombosis in the iliac or the common femoral vein, then we have to do pharmacological thrombolysis, which is urokinase, streptokinase, or a mechanical thrombectomy. Mechanical thrombectomy is nothing but pass a probe through the vein, and the probe goes ahead of the thrombus, a basket opens up, and then we extract the thrombus out through an opening in the vein. This is all done under the X-ray guidance, and yeah, so it's mechanical thrombectomy with or without thrombolytic infusion. So we always give a thrombolytic infusion basically. And even if the mechanical thrombectomy fails through small approach, then we have to open up and do a surgical thrombectomy where we, under our own eyes, we cut open the vein and we take it out manually. It's indicated for failed pharmacologic thrombolysis or failed mechanical thrombectomy. Okay, so this is how. So, what are some of the surgeries with high risk factors for the formation of deep vein thrombosis and pulmonary embolism? Any case with a hip or leg fracture, neck or femur, IT fracture, tibia fractures, proximal tibia, distal tibia, doesn't matter. But hip fractures more so than leg fractures, hip or knee replacements, any major general surgeries like lab surgeries or even explorative labs, like in case of trauma where we might have to open up and check manually, polytraumatic patients where there are multiple fractures, any patients with a spinal cord injury who are paraplegic, all these are strong risk factors for formation of DVT. As you can see, an arthroscopic knee surgery falls under a moderate risk category. And these are all the weak risk factors. So, how do we decide whether we want to give thromboprophylaxis to the patient? We use something called a Caprini score. And again, like here, we go through these tables and then we give 1 point for all these, 2 points for all these, 3 points for all these, and as you can see, 5 points for hip, pelvis, or leg fracture, elective arthroplasty, acute spinal cord injury, and stroke. So 5 points directly for all the major surgeries that we do in orthopedics basically. And so you can see Caprini score 0 is the lowest. Early frequent ambulation is usually more than enough. Caprini score 1 to 2, which is the low risk category. We usually give compression stockings or low dose heparin, sometimes depending on case to case basis. 3 to 4. From here on, from moderate risk category, we usually give compression stockings and low dose enoxaparin, 40 mcg subcutaneously. And it is only during the hospitalization period. And post hospitalization, we usually discharge them on ecosprin. 5 to 8 Caprini score, which is a high risk category. We give 7 to 10 days total of low molecular weight heparin and discharge them on oral anticoagulant. And then for a Caprini score greater than equal to 9, which is the highest risk, we have to give compression devices, whether it's stockings or pneumatic calf compression devices, or and low dose heparin for at least 30 days total, according to the guidelines. So what are some ideal guidelines to follow? In our institution, we follow a certain set of guidelines, but these are the nice guidelines, and this is what is used in the United Kingdom. And so after their elective total hip arthroplasties, as you can see, they give low molecular weight heparin for 10 days, followed by aspirin. So 10 days of low molecular weight heparin, followed by 28 days of aspirin. So total of around 38 days of treatment. And also, so this is one option. The second option is low molecular weight heparin itself for 28 days with compression stockings. And then the third option is we give either of these, rivaroxaban, apixaban, or dabigatran for a period of 28 days. So this is a one option, this is the second option, and these are the third options. Either one of these, not all three. In case of total knee arthroplasty, they had removed aspirin initially, but now they brought back aspirin. We usually give 150 milligrams for a period of 14 days. We actually give it for a period of 30 days, but according to NICE guidelines, it says 14 days is enough. And low molecular weight heparin and compression stockings for a period of 14, so either aspirin or low molecular weight heparin, or rivaroxaban, apixaban, or dabigatran for a period of 14 days. 1, 2, 3. So either of these, not all of these together. In our institution, we usually give 3 days of low molecular weight heparin, and after that we convert to aspirin following knee replacement for a period of 1 month. So we give 3 days of heparin followed by a month of aspirin 150 milligram. But as you can see, what they do in the NICE guideline is slightly different. So these are some of the other guidelines. American ACCP guidelines 2012, AAOS guidelines, and have a SI sign guidelines as well. This is the American Association of Orthopedic Surgeons, and I think ACCP is American College of Clinical Pharmacy, if I'm not mistaken. Okay. Yeah, American College of Clinical Pharmacy, correct. Yeah, so these are the guidelines we roughly have to follow, and I showed you how to diagnose and find out if the patient has DVT. And yeah, thank you guys.